All right. Good afternoon, everybody, and welcome to SEVA VentRounds. Today is May 16, 2023, and today's case is one of pure and clear sabotage. And this is a case that was confused and solved by a Capnogram. And so we're going to share this case for you in the next 30 minutes. The disclosures is we will discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo Mireles, and Rob Chatbur, you can see him also online saying hello right now. And there's our disclosures for what we're going to be talking today. There's some ground rules. If you are online, please keep your microphone muted. We may call upon you according to what you put on the chat. Or if you want to say something, just put it on the chat, and then we, if needed, we'll give you a call. Just use the chat function. There is CMEs for Cleveland Clinic employees, but also for our respiratory therapies. There's CRCE, so enter your name in the chat to verify your attendance, and there's an evaluation that we will put out at the end of this on the chat, and then you just complete that and you get a high quality CRCE for being part of this. So all good. So as every time that we start one of our SEVA VentRounds, we have some SEVA basic knowledge that will be important for all of us. And what you have here is a graph. This is a capnogram, and one thing to recognize is that in the y-axis you have the pressure of CO2, and then on the x-axis you have time, and this is key because on the capnogram you have time in when you're doing volumetric capnography, then instead of time you have here volume. But today we're talking about the capnogram in itself. And so there's four stages for the capnogram. And this has a lot to do with ventilator because you can use this as a tool to help you identify patient ventilator interactions. And so during phase one in the capnogram, it's during inspiration. So while the patient is getting air into their lungs, the sensor, which is in the Y of the ventilator, is seeing fresh gas go in, which should have no CO2. Then when the inspiration ends and the patient starts inhaling, you're going to see phase two. And during phase two, you're going to have a mixture of airway dead space and alveolar dead space that and gases that will cause this slope to occur, which you see over here. And finally, you're going to get to stage three, which is essentially alveolar gas, and it's going to be increasing, but essentially plateaus, and it remains, and it's just a sample of the gas inside the alveoli that is carrying all the CO2. And then when the next breath starts, the inspiration goes, then this phase four occurs, and it drops so rapidly to again start the phase one. And so the important thing is that when you're looking at the capnogram, you may see the formations on the capnogram that may tell you that something is going on in terms of the presence of PMOS. So if you see deflections that move down, that look like this, that tells you that the patient is, or it hints towards the presence of flow that is going into the patient, so that it's dropping. So it tells you that something, usually we think that it's activation of the muscles, so there's inspiration. Or you could also have that the patient tries to breathe out, and you may see it go up and tells you that there's expiration. And so those are markers that we're taking a look that may tell us that something is happening. And the same during inspiration, you may see bumps out that tell you that the patient is actually trying to exhale through the circuit, and you're seeing those humps and bumps in your sensor, which usually sits at the Y. And for those of you that are having issues with what the Y is, essentially is the inspiratory circuit that coming from the ventilator and the expiratory. So here's the ventilator, the vent. And then here's the connector to the ET2, and then this goes to human, and the sensor would be around here and capturing the signal to give you this entitled CO2. Rob, thoughts?
Good.
All right, and with that, we move to this. This is the case in point, and what you have in this graph, you can see on the top, this is out of the ventilator. You have the mode itself, you have the pressure, flow, volume, and then the capnogram for this patient. And so you have time, and then you have the CO2 concentrations in millimeters of mercury. And so in usual fashion, what I would ask you to test yourself is to start writing your tag, and you can put it on the chat, what the tag is. What do you think is the load? Meaning if there's elastic, resistive, or there's the presence of PMOS, if there's any patient ventilator discordance in terms of trigger, inspiration, cycle, and expiration. And so please go at it and tell us what you think is going on. And I usually give you a minute here. Nothing is paused. We're just waiting to see what comes out on the chat. Have no fear. The chat is not visible to the recording, and it's just us trying to learn here what you see. All righty. As you are typing in and pondering on this, we'll start on it. So, Rob, do you want to give it a trial? Okay, I see some entries coming in.
Sure. From the pressure waveform, we're just going to ignore the name of the mode for the time being. On the pressure waveform, we see constant inspiratory pressure, so that suggests pressure control, and we see an exponential decrease in flow, which again suggests pressure control. It's a relatively short inspiratory time, looks like about a half a second. So it's not surprising that flow doesn't reach zero during the inspiratory time. These are patient-triggered breaths, okay, because you can tell from the white, these are in the pressure waveform. So these are pressure-triggered breaths. It's hard to appreciate whether or not they have the same inspiratory time or not, but I'm going to cheat and look at the name, volume support. And the volume, the VS is highlighted, so or lit up in white, so that means these are spontaneous breaths, patient triggered, and flow cycle, patient cycle. So we see here what looks like 2 spontaneous breaths in pressure support. And because you can set a tidal volume, if you look at the bottom, you set a tidal volume, so there's a target for tidal volume. That means this is adaptive. And because it's auto mode, we know it's IMV type 2. You can't tell by looking at it. You have to tell by knowing the tag for auto mode. So pressure control IMV type 2, mandatory breaths are DRVC, which is adaptive, and the spontaneous breaths are volume support, which are also adaptive. Is that what you wanted?
Yeah, thank you very much, Rob. And this is essentially, if I had not put this in the screen, the top, you would not be able to distinguish it from volume support, right? You would have said this is PCCSBA just by looking at it. And the only way to know this is that it flips back and forth with the presence of PMOS, correct?
Correct. That's why it's
So,
IMV type 2.
yeah.
So the spontaneous breaths suppress mandatory breaths in IMV type 2.
Yeah, and this is one of the key items that I think that it brings a little bit of brain activity towards the badness of when people say, oh, it's IMB, we don't use IMB, that's a bad word. And it just tells you that it's in this setting, essentially you're in one mode or the other. You're either on volume support or you're on PRVC, depending of you if there's a presence of PMOS. But we call it IMB because both breaths can exist, both spontaneous and mandatory breaths. It's just the algorithm. Very good. Thank you, Rob, for doing this. Now, the load is a little bit tricky, but let's do this together. So when we talk about the load, and because this is pressure control, Rob, you would say that we look at the flow, correct?
Correct.
And so if you look at this, what load would you give? Elastic, resistive, or would you say there's a lot of PMOS and I cannot see?
You asking me?
Yeah, since you are the master of elastance.
The evidence of PMOS in pressure control is found in the flow waveform. And we know that flow waveforms should look like a decaying exponential, which is probably what this would be if we had a long enough inspiratory time. I don't see any bumps, particularly positive going bumps, which would indicate an inspiratory effort in a form of PMOS. So right during the inspiratory phase, I don't see any evidence of PMOS.
Would you think that this is elastic or resistive?
Oh, I would say elastic, because well, first of all, it's because you can't really tell, as far as I can say, from the inspiratory waveform because it's a short inspiratory time. But if you look at the expiratory curve, you see that the flow goes back to baseline within a second and a half. And so I would say that's normal or elastic load. That's not a resistive load.
So by inference, we're thinking that the inspiratory looks like elastic, right?
Could be. Huh?
Alrighty, and not much PMOS there. So now we have defined, we have elastic load. We know that the breath, that there's some PMOS because the breath is a spontaneous breath. We read it as a spontaneous being triggered by the patient. And so let's look at the patient ventilator discordance. And in this case, we have either the option is normal, early, late, false, or failed. And false meaning that something else is triggering the ventilator, or failed meaning that the PMOS is not triggering the ventilator. And as I look at the chat, I see a couple of items here that are coming. I think everybody agrees with what you said, Rob, which is good. And then there is the fail. There's a thought that this is a fail trigger. And so as you look at this waveforms, let's start by it. So it's in this case it's pressure triggered, or it seems to be pressure triggered because it's the color change is out in the pressure waveform. And there's a little bit deflection, negative deflection before the breath. So it does look like the patient is doing, and you see the flow actually cross above the baseline. And so triggering the breath. And so these ones look like normal breaths when you see them at face value on this image. Then you see there is no evidence of PMOS during inspiration. So I would say, because this is patient trigger, so this cannot be early. So I'm just going to cross what it cannot be. I don't see it being late. There's no big dip before it. In terms of false or failed, there's a lot of irregularities on the flow waveform. You can see them throughout. But it's just triggering here and here. And however, when you come down and you look at the capnogram, and you can see the capnogram down here, you see inspiration occurring, and it goes to phase 1, so there's nothing. And then phase 2 occurs rapidly. It races really rapidly as exhalation is happening. And then you see exhalation, and there's it kind of reaches a plateau here, and then after that there's this hike up, another plateau, and then there's this dip, and then again goes up, and there's another dip. So the question is, when you see these dips, this would tell you, this dip over here and this dip over here, you would interpret them as a as the patient was failing to trigger the breath. Actually, you can see in correlation with this dip, there is this hike on the volume, and there's a hike, a rise on the flow, and there is this drop in pressure. So this would be consistent with a failed trigger, as Victor is saying. And here I don't see much change, but I do see those aberrancies on the flow and the pressure waveform. Rob, thoughts?
Looks good.
Yeah, so initially when you see this, you would feel that this presence, and this is a classic image for somebody that has what we would call a failed trigger, and and this is basically that the patient is doing PMOS, and it's not triggering the ventilator, and you see some aberrancies on the flow and the pressure waveform that supports that. And sometimes you cannot see these very well because the gain or the scale on the pressure waveform or the flow is not good enough to show you those aberrancies. And so they may be happening, but you don't see them as well as you should. During inspiration, I don't see any evidence of PMOS. Actually, it decays exponentially in both of them, but sometimes it's so short that you may not be able to see it. So I would say that there's no severe work shifting. I mean, it seems that it's triggering. I don't see much PMOS, but I would not be confident to say that it's over assisted. It's not definitely under assisted, and so it may be normal. I would say, if I read this one initially, it would be normal, because I don't see anything else here that would tell me otherwise. And then in cycle, I don't see evidence of an early cycle. There's no hike here, and there is no and there's no evidence of early. Perhaps, I mean, there's no early because there's no PMOS here, and there's no late because it's not going. There's no pause afterwards. You don't see any hikes on the pressure or anything like that. So I would say it's normal, just by reading it right now. And then in expiration, there's no evidence of PMOS, so I would say it's normal. So my initial read of this waveform is similar to what is coming out here, is that it's a failed trigger with a normal inspiration, normal cycle, and normal expiration. Rob, would you agree, disagree, or say you're full of prunes?
Prunes.
Full.
I would absolutely agree. As far as it goes, I think there's something strange about the CO2 waveform, but we can get to that.
Yeah. And so you can see that there. So what would be if you think that this is a failed trigger, what would you do next? What would be the next item that we would do to fix that? Just write it on the chat. Have no fear. So I see a couple. So in a patient with failed trigger, they're saying decrease the sensitivity. I see that sensitivity, and then there's one about decrease the target. So here you're trying to figure out, you have to define what the etiology you think for the failed trigger. And this is important for us to review a little bit about what are the potential causes for a failed trigger. And so the classic causes for a failed trigger are three. that I would group them in three. Conditions that cause auto PEEP, so increased resistance on the airways. Conditions in which you cause over assistance for these patients, so they get very large tidal volumes for the amount that they need. And then third is the that you set the threshold inappropriately. And so there's keys for all of these items when you see them. And if you think about this, if this was auto PEEP, you would expect an increased resistance, which you don't see here, right? That would be an item. And so if you don't see increased resistance in your flow waveforms, it essentially takes away the thought about this being auto PEEP from obstructive lung disease. So that's out. The second would be over assistance, in which you have a very large tidal volume, and the patient, usually you see that the efforts occur while flow is still coming out. And you can see that those efforts are occurring with the flow is zero. So that takes out over assistance too. And the third one would be that the threshold for pressure is set too high. And usually the key item that you would see there is that you would expect to see a drop in the pressure when the patient is triggering, that it goes below. I mean, it's marked for that pressure trigger. Now, it could be that we don't see it because that gain is set inappropriately. So that's what it's left. And so there's a thought here about, well, let's change the sensitivity. And so the astute respiratory therapist involved went ahead and changed the threshold. And now you can see they changed the trigger to 1.8, so it changed to flow trigger, and now you can see the flow trigger is active right here, right? And so now you see each one of the breaths are active. That's beautiful. And there's no drop at all in the end-tidal CO2 tracing. So these got this tracing that we had over here that looks like a false trigger. When they change the threshold on the trigger, your end-tidal CO2 waveform changed, and now you have every breath being triggered by the device. Rob?
Yeah, I have a comment. I generally think of it this way. The problem could either be on the patient side, meaning low effort, on the ventilator side, meaning low sensitivity, or a patient-ventilator interaction problem, which in this case would be auto PEEP. Now, you mentioned over assistance, and that's a little unclear to me because over assistance could lead to a low CO2, which would give you a low effort, or it could lead to auto PEEP, which would be the PVI interaction. So your term over assistance is not clear to me. Could you explain that?
Yeah, so when you see usually the over assistance, what you see is the waveforms for the next breath are occurring during expiration, and so the tidal volume that the patient got, they are still trying to exhale. So there's in a sense a form of auto PEEP, Rob, but it's generated by large tidal volumes rather than resistance in
Right.
its.
So there would be auto PEEP if you did an expiratory hold at that point when they made the effort.
Yes, but it's caused by over assistance, but
Right.
not by the classic auto PEEP that you would consider.
Yep.
Yeah. So yeah, that's thank you for highlighting that difference.
So that would be a machine side problem.
Yeah,
So you have low sensitivity or too high tidal volume.
that's correct.
Okay.
That's
Good.
correct. And so, but there is a cool item here that, I mean, when we saw this patient, we saw the patient a couple of days afterwards, these images. But if I'm not incorrect, and Ariel can prove this, is that the patient was paralyzed during these images. Correct, Ariel? Yes. So patient is paralyzed, and this is the waveform. So this image that we have here of a failed trigger turns out to be a patient that was on auto mode with volume support while paralyzed, and the patient should be on PRVC. And so, isn't that interesting? So, what we did then was an end expiratory pause on this patient, and this highlights actually the classic a classic view. You can see here, because of the threshold that or the gain, you're unable to see any flow aberrancies, right? It looks essentially flat. The pressure looks essentially flat. But when you come and see the end-tidal CO2, you can see these massive oscillations that are occurring. And we did change the gain again on this, and you could not see them as well as you would expect. I mean, you can see a little bit out of them. So we grabbed the monitor, we connected an end-tidal CO2 transducer, and now you have here the central venous pressure, which is transmitting also the cardiac oscillations of the patient. You can see the pulse ox, the arterial line, and the EKG. And this waveform, these aberrancies match beautifully with each one of our deflections on the end-tidal CO2, proving that this patient was having a false trigger as a cause of the patient ventilator desynchrony. So this was an asynchrony actually. It was a false trigger that we could not see, and the thing that showed it to the team was the end-tidal CO2. Thoughts?
It's odd that before you changed the sensitivity, this patient wasn't hypocapnic, was he?
No.
He was doing okay with a cardiac trigger. That's
Yeah,
probably
that's
why
correct.
nobody
So,
noticed it, right?
yeah, you can see that the end-tidal CO2 went down when they
Yeah.
changed the trigger. So now the patient was hypocapnic on that circumstance, but it was all triggered by the machine. And you can see the size of the oscillations that the patient is having are big enough for the the patient. This is really interesting to see. So we got sabotaged by the Capnogram, thinking that this was classic for a failed trigger, and then it got solved by a Capnogram, which demonstrated the cardiac oscillations and how they matched with the cardiac cardiac rhythm.
So your clue that there was something wrong after you fixed the sensitivity was that the CO2 went down, right?
Well,
What would drive the patient to do that, right?
I mean, in hindsight, this is the classic case. We see this very often. The patient is paralyzed or brain dead, and there's continues to be triggering of the ventilator, and the team then starts troubleshooting this, and they go through a series of items. A is the infusion going into the patient or not? And this has happened because now we use more peripheral. So you say, well, is the patient appropriate? And what we have now for paralyzed patients, we rather have a central line just in case that something would go not into the vein. So imagine that you are now paralyzed and not sedated because it's not going in. Or they say, well, is this the right medication? Are we at the right dose? Or they start doing other measurements to see if the patient's paralyzed. And because we do not aim at having them fully paralyzed, so we use the train of 4 at times, they see that there's still a sensitivity, and they start going up on the paralytic. And then finally somebody comes and, I mean, sometimes they reach the conclusion much earlier. I'm just putting here a long protracted course in which then they say, well, maybe it's a false trigger. And if you see an image like this one over here, it's if you have the capnogram, you may suspect it, but if you don't have a capnogram, it would be really hard for you to suspect that on passing, right? So the capnogram helped here to unmask the wrong thing, but which was the right thing in hindsight. And that's why I think now in as I think about this, is if you think about those patients with failed trigger and you think about those three items that can cause them: over assistance, auto peep, and the wrong threshold, and each one of them have particular ways that they look on the waveform. And this doesn't look like any of them, right? This doesn't
Yeah.
look like any of them.
So the outstanding feature of this case is that the patient was supposed to be paralyzed, but couldn't this happen on somebody that wasn't getting a paralytic?
Yeah, it can. And
Then
actually later,
you're really screwed,
when,
right?
when I met this patient, the patient was having exactly the same thing, but the paralysis and sedation had been stopped. But the
Yep.
patient was deeply sedated still from what was happening. And so the patient had switched again to volume support uh, because it seemed that it was triggering, but the patient was in La La Land. So I mean, this have implications in general for patient care. And you can imagine for somebody that you're talking about brain death, and you say, well, there's respiratory effort uh, in the ventilator, rather than doing a pause and looking if there is really or not. And so when you do the pause, you can see what looks like effort, but you don't see any effort over here. So Victor asked why the patient is on auto mode. Well, at that time, the patient was on auto mode because she was coming out of paralysis, Victor. So that's one of the reasons. And you can think you can have anybody on auto mode and say, well, why do you have them? Is because they are on PCCMB, and then when we stop the sedation or the paralysis, then they can switch to volume support. So you can make an argument there, but that was the argument at that time.
So
So
what
with
did you do
that,
to fix that patient? Did you just decrease the sensitivity or what?
yeah, we changed then the sensitivity. We made it harder for the patient to trigger, and then I mean, there's some images on how the patient woke up and started to trigger on their own. So here are the CMEs for caregivers. There's a link from Ryan on the chat. Please log in, get your CRCEs. We want to support it. If you are one of our staff, please get your CME. We're happy to provide those. As usual, we appreciate your sending us waveforms, sending comments. There are emails. There's my Twitter account. Rob doesn't use his anti-Twitter now, and so do share with us, and we'll go from there. All right. Any other questions, comments? Fascinating case. Thank you. Thank you all. Have a good day.